Welcome to chapter 27, the second part of the reproductive system. We're now going to do the female reproductive system. Right here, you're looking at the mid-sagittal section of the female reproductive system. The reproductive role of the female is more complex, and it's because of pregnancy. The ovaries is actually the female gonads because they produce the female gametes, which we call ova, and they secrete the female sex hormone estrogen and progesterone. The internal genitalia is located in the pelvic cavity, and this includes the ovaries and the duct system, such as the uterine tubes, the uterus, and the vagina. The external genitalia is actually outside of the body cavity and is known to us as the external sex organs. The ovaries are paired structures that flank the uterus, and they are almond-shaped and about twice as large as an almond. Each ovary is held in place by several ligaments, and the first to consider is actually your ovarian ligament. The ovarian ligament anchors the ovary medially to the uterus. And you have the suspensory ligament. The suspensory ligament is somewhere around here and it goes all the way up. It anchors the ovary laterally to the pelvic wall. Then you have the mesovarium. The mesovarium suspends the ovary pretty much, uh, and the suspensory ligament and the mesovarium is actually part of a broader um, mesentery, and this is actually what you call the um, broad ligament. So the broad ligament pretty much suspends a lot of things in it, and part of it is actually the suspensory ligament. But then let me point out that the broad ligament has several names. The broad ligament right within the vicinity of the ovary is actually called the mesovarium. Right within the vicinity of the uterine tube, right in this section here, you call that the mesosalpinx. And right within the vicinity of the uterus, you call that the mesometrium. So your broad ligament supports the uterine tubes, the uterus, and vagina. Now, the blood supplies for the ovaries is actually your ovarian arteries, okay? The ovarian arteries, which is actually like part of that suspensory ligament, goes through inside the broad ligament through the um, with the suspensory ligament of the ovary. And pretty much this is actually branching off the abdominal aorta. And each ovary is surrounded by a fibrous tunica albuginea. You could see the tunica albuginea here. It's actually whitish. Uh, it's a whitish cover. It's made up of connective tissue, and is covered by a germinal cuboidal epithelium outer layer. The germinal layer is a continuation of the peritoneum, the blood supply for the ovaries, which is your ovarian arteries, um, goes inside and is actually coming from, oh, I mentioned that already, coming from the, uh, what do you call this, coming from as a branch of the abdominal aorta. Now, the ovary this is a cross section of the ovary, a photomicrograph of the mammalian ovary. You could see that it almost looks like the follicles of the ovary are actually all over the place when they're supposed to be only like within the cortex. Unfortunately, the cuts right through the cortex on one side of the ovary, and therefore the visibility of the medulla of the ovary in this particular slide is not really very good. So I want you to know that the ovary itself has an outer cortex that houses all the forming gametes, and it has also an inner medulla that contains large blood vessels and nerves. The ovarian follicles, these are your ovarian follicles right there. Okay, and those little ones too are your ovarian follicles. Those are really tiny follicles. Now, these are tiny sac-like structures embedded in the cortex. They contain immature eggs, the oocytes, as encased by one or more layers of very different cells. And each month, a ripened follicle would eject an oocyte in an event which we call ovulation. The uterine tube system emerges right here, right in this area here, all the way to the distal part, which is actually like a bell-shaped end, and which is called the infundibulum. That would have finger-like projection, which are called the fimbriae. That's the entire fallopian tube or uterine tube. The tube system, though, is made up of the uterine tubes, the uterus, and the vagina. The uterine tubes is also known as the fallopian tube or oviducts. They receive the ovulated oocyte and usually is the site of fertilization. So the ovulated oocyte is released by the ovary. It is picked up by the fimbriae and the mucus that is produced by the fimbriae, and then by way of peristalsis moves along the entire length of the uterine tube. And it is in this particular place where there's going to be like coitus. If the female has received sperm cells, it is in this place that the that the eggs, the secondary oocyte, will actually be fertilized. And the tube is about 4 inches long, and it an area um, extends from the area of the ovary that is superior to the superior region of the uterus. Regions of the uterus of the uterine tube will be your infundibulum, the fimbriae, the infundibulum, which actually has finger-like connections, which is called the fimbriae. Then you have the tube itself, okay, and uh, pretty much it ends all the way to the uh, the isthmus. It's a narrow medial third, narrow becomes narrow right here, okay? And it empties into the supero or an upper lateral region of the uterus. During ovulation, the uterine tube captures the oocyte. The fimbriae sweeps it, okay, and uh, pretty much with the peristaltic peristalsis of the uterine tube, the oocyte is now carried into the tube or right through the tube. And there are non-ciliated cells also that are found in the uterine tube. The non-ciliated cells produce nourishment for the oocyte and the sperm. So externally, the uterine tubes are covered by a peritoneum and is supported by a short mesentery part of the broad ligament, which you call the mesosalpinx. Now, the uterus, this is actually your pear-shaped uterus. It's made up of the body, okay, the body, the fundus, which is the rounded superior region, the isthmus, right in this area here, that region right there, and the cervix, okay, this area here, which is actually a narrow neck or outlet that projects into the vagina. The cervical canal communicates with the vagina via the external os and via the uterine body via the internal os. The mesometrium pretty much is the lateral support of the broad ligament and is the one that supports the uterus. We have also uterosacral ligaments, and they secure the uterus to the sacrum. We have also the round ligament. The round ligament is very visible right there. The round ligament of the uterus uh, binds the uterus to the anterior wall. The sacs of peritoneum exist around the uterus and creates a vesicouterine pouch between the bladder and the uterus, and a recto-uterine pouch between the rectum and the uterus. This is a mid-sagittal cut along the pelvis of the female, showing you another view of the uterus. Here you can see the uterine wall because the uterus has been cut mid-sagittally, and there are three layers of the wall. The perimetrium, which is actually the perimetrium, which is the cover, the outermost visceral peritoneum of the uterus. The myometrium, which is actually the muscular, middle, bulky muscular layer made up of interlacing layers of smooth muscles, which contract rhythmically during childbirth. And then the innermost layer, which is actually the endometrium, which is the mucosal lining made up of simple columnar epithelium on top of a very thick lamina propria. And pretty much the fertilized egg from as it travels through the uterine tube will eventually burrow into the endometrium and reside there during its development. And here's a photomicrograph of the endometrium, showing us also the blood supply and showing us the layers. And it has two chief layers or strata. The stratum functionalis, or the functional layer, is a very thick layer right here, so which is every month at the end, together with the menstrual period, is being sloughed off, but is also renewed every month. Then you have the basal layer. This is not shed, unlike your functional layer that is shed monthly. The basal layer is not shed, but is actually like the one source of the new stratum functionalis after the after menstruation. This is actually the one that rebuilds the functional layer of the endometrium for next month. And this stratum basalis is actually unresponsive to ovarian hormones. This is a different view showing us the blood supply of the endometrium. The uterine arteries, and the arteries are the red ones, the veins are the blue ones. The uterine arteries arise from the internal iliacs and the arcuate arteries in the myometrium, and they branch into the radial, well, actually the radial arteries. This is your radial artery right there, and the radial artery branches into straight arteries, which is actually the one that would pretty much like deliver blood to the stratum basalis, and the one that would nourish the stratum functionalis will be the spiral arteries. This is the one that serves the functional layer, and they would repeatedly degenerate and regenerate monthly as they are being sloughed off. It's going to be regenerated by the stratum basalis stem cells. And here is actually um, looking at the uterus and pretty much the different positions of the uterus in different females. The normal uterus is anteverted, which means it is leaning forward. Now, retroverted uterus does not lean forward, but is actually straight up. Then you have your uterus, or a what do you call this, an unusually shaped uterus, which is sometimes poses a problem, is actually a retroverted uterus that is actually flexed backward. Now, being retroverted and anteverted does not really pose much a problem in pregnancy. However, some women with retroverted and flexed uterus have problems getting pregnant because of the positioning of the uterus. And here's another homeostatic imbalance showing us an ectopic pregnancy that is outside of the uterus. This oocyte is fertilized in the peritoneal cavity on the distal part of the uterine tube and begins developing here. It normally aborts naturally with substantial bleeding, but this one, I believe, is actually being removed or taken out. And here's another homeostatic imbalance of the uterus. Now, this is called the prolapse of the uterus. This happens when an unsupported uterus may sink down right into the vagina and would eventually be moving out of the vaginal canal until pretty much the tip of the cervix right here protrudes through the external vaginal opening. This is caused by overstretching and sometimes tearing of muscles during childbirth. Now, even though the uterus has many anchoring ligaments, it is principally supported by the muscles of the pelvic floor, and that is actually very much prone to damage. And here's the external genitalia showing showing us showing also the perineal or perianal diamond shape. All external genitalia, both the male and the female, is actually within the perianal or the perineum, which is actually a diamond-shaped area in our groin area. Now, the vagina is a thin-walled tube about 3 to 4 inches in length, and it functions as the birth canal and also as a passageway for the menstrual flow and it's actually the organ of copulation. It extends between the bladder and the rectum from the cervix to the exterior urethral from to the exterior urethra, and it runs parallel to the vagina anteriorly. The layers of the vagina usually is outermost layer is a tunica uh, adventitia. It's a fibroelastic adventitia. Then a middle layer of muscularis and an inner stratified squamous mucosa with rugae. The vaginal secretions usually in the adult are very acidic and alkaline in the adolescents. The mucosa near the vaginal orifice forms an incomplete partition right in this section right here, which we call the hymen, and it ruptures during most especially during the female's first intercourse. The upper portion or the upper end of the vagina, which is the vaginal fornix, is actually the one that surrounds the cervix. Okay, so the female genitalia, external genitalia, is also known as the vulva. Okay, entire thing here is the vulva. And on the most anterior part is actually the fatty area that is pretty much like covered with uh, hair, pubic hair, which is called the mons pubis. The labia major is also hair covered and it's fattest skin fold that pretty much covers the labia major. Then you have uh, right inside or underneath the labia minor is actually right within the vestibule, within the recesses of the labia minor, is the greater vestibular glands. The greater vestibular glands, you cannot see it here. You have to remove the labia minor to see that. It is homologous to the bulbourethral gland of the male. It releases mucus to the vestibule for lubrication. Then you have the urethral opening. Anterior to the urethral opening is the clitoris, which is the homologous or the homologue of the male penis. And it is really a homologue because our clitoris or the female clitoris also has a prepuce. The only thing is that uh, whereas the male prepuce is removed in a surgical procedure called circumcision, the female prepuce would rather not be removed because of the um, size of the clitoris. It's very small, very tiny. The perineum is this, just like what I mentioned, is a diamond-shaped region between the pubic arch and the coccyx. It is bordered by the ischial tuberosity laterally. Of course, these are bones. It's underlying bones, and it overlies a muscle of the pelvic outlet. It is the posterior ends of the labia major and overlie the central tendon. The milk-secreting mammary glands, the breast. Mammary glands are present in both male and females, but the female pretty much is the only one that would be functional. The main function of the mammary gland will be milk production to nourish the newborn. And since the male does not get pregnant and will and pretty much then pretty much their mammary glands are not supposed to be active unless there is something wrong. Now, mammary glands are modified sweat glands and are made up of 15 to 25 lobes. And the breast would have a characteristic pigmented area, which you call the areola, surrounding the nipple. And inside, there's actually like suspensory ligaments that would be attaching the breast to the underlying muscles. The lobules pretty much are, each of these are lobes. Okay, these are uh, what do you call this? These are the ones that carry the lobes that are the glands, the glandular alveoli that produce the milk. And the milk is passed into the lactiferous ducts, right there in the lactiferous ducts, into the lactiferous sinus, and then it pretty much like opens out into the opening of the lactiferous ducts. In non-nursing women, the glandular structure is undeveloped, and the breast size is due to amount of fat deposits that is actually surrounding the gland. Now, let's look at some problems, okay, um, of the human breast, and that's actually the invasive breast cancer, and it's the most common malignancy and the second most common cause of cancer death in the United States. 13% of women will develop the condition. It usually arises from the epithelial cells of the smallest ducts that eventually metastasize. Risk factors for breast cancer usually is early onset of menstruation and late menopause. Or if the female has no pregnancies, or the first pregnancy pretty much was very late in life, and pretty much or there's no or short periods of breastfeeding, so or a family history of breast cancer. All of these are risk factors that may lead to the female having breast cancer. But 70% of women with breast cancer has no known risk factor. They're not even, they don't even belong to these risk factors right here. And most of the women with breast cancer, though, 10% of them is actually due to hereditary defects, including mutations to genes, the breast cancer gene 1 and the breast cancer gene 2. And about 50 to 80% of women with these genes develop breast cancer. The greater risk of ovarian cancer, as well as its diagnosis, sometimes do not jive with each other because there are some women that do not fall on any of these risk factors at all, but they develop breast cancer. So there are still underlying factors that scientists feel could cause the breast cancer, and some of them probably we have known already, a lot of them, because it is a well-studied area, but up to now, we do not have any cure for breast cancer. So we do not know any um, other risk factors. There may be some underlying risk factors with which we have not tapped yet. So what are the stages of breast cancer? Well, breast cancer has 4 stages, but if it starts with zero, the zero means carcinoma in situ. Okay, so non-invasive. This is actually non-invasive cancer that's confined to the milk ducts or lobules of the breast. Stage 1 is actually a small tumor that is less than 2 centimeters that has not spread to the lymph nodes. Stage 2 is actually a large tumor, it's about 2 to 5 centimeter, or tumor that has spread to a few lymph nodes. Then stage 3 is a large tumor that is over 5 centimeters, or tumor that has spread to many lymph nodes. Then stage 4 is a cancer that has spread to other parts of the body, such as the bones, the liver, or the lungs. There are other factors, pretty much, that we can consider in looking at or assessing the stages or the severity of breast cancer. Pretty much, the first one is actually the lymph node involvement. The number and location of lymph nodes that's affected by the cancer can influence the stage. Now, the second one will be a hormone receptor status, whether the cancer cells express estrogen, progesterone, or HER2 receptors can affect treatment and prognosis. Now, the grade is the aggressiveness of the cancer cells. It is classified as low, intermediate, or high. It is important to note that these stages are only general guidelines, and individual cases may vary. A healthcare or the doctor will determine the specific stage of the breast cancer based on physical exam, imaging tests, and the biopsy result. Early detection with the use of your own self-examination is very important. And also getting yourself a mammogram. It's actually a type of X-ray examination. It is not really a comfortable type of examination, but the American Cancer Society recommends screening every year for women age 40 and over. But there's another group, the U.S. Prevention Services Task Force on Breast Cancer Screening, would recommends delaying the mammography until the female is already age 50. But if you know that your mother has had cancer or someone very close to your family had died or had breast cancer, do not wait until you are 50. You have to let your doctor know that it runs in your family so that you can be screened immediately. The treatment depends on the characteristic lesion, um, should be radiation and chemotherapy or surgery that is often followed by radiation and chemotherapy to destroy spray cells, and drugs that are available for us. Drugs for estrogen responsive cancers will be uh, your Herceptin for aggressive cancer cells, tamoxifen, which actually improves the outcome for premenopausal women with early or late stage cancer. And then Femara reduces recurrence. And until 1970, the standard treatment pretty much was radical mastectomy. It is usually the one that removes the breasts with all of the underlying muscles, fascia, and associated lymph nodes. Lumpectomy also is a less invasive, and it cuts off or excises only the cancerous lump. Simple mastectomy, on the other hand, is removal only of the breast tissue Sometimes some axillary lymph nodes may be removed. Pretty much after this, the female breast would not be looking good. Therefore, some women would opt for breast reconstruction. Going forward into the female reproductive physiology, let's try to look at the events in oogenesis. Oogenesis is the production of female gamete, and it begins in the fetal period. The oogonia uh, is actually divided by mitosis in the beginning to produce the primary oocyte that would undergo meiosis 1 to produce the secondary oocyte that undergo meiosis 2 to produce the ova. So right here, this is actually your oocyte that is available already to us even before we were born. So at birth, all of the primordial follicles are already present and contain already many oocytes, and these oocytes has already started to undergo meiosis 1 and has halted meiosis 1 in prophase 1. They have already undergone crossing over synapses and everything, but they they are actually in uh, they have arrested or they stopped meiosis 1 under prophase 1. So they had not even reached metaphase. They're still in prophase 1 until we're born. And until we're born, it's still in prophase 1. It will only continue and move on, proceed into metaphase uh, once we reach puberty. So these eggs are actually inside a follicle. So all of the primordial follicles are already there in our ovary before we were even born. And all of these follicles contain all of the eggs that we are supposed to uh, be ready with for ovulation throughout our entire sexual life. From the time that we get into puberty, the female gets into puberty, all the way to the time that she will already lose the menstrual period, which is a menopause. So all of the all of the eggs are already there, ready, and but they have not undergone and completed the meiosis 1. They are actually all arrested in prophase 1. So let's take a look at the first, before we get into the actual meiosis event itself. Let's try to look at what's going on with the egg itself. So being that you have already your oocyte and you have already your pregranulosa our primordial follicle bearing the oocyte, what's actually inside the primordial follicle is actually the primary oocyte already. It is not anymore in the oogonium, although the oogonium or the stem cell would still be available to us uh, if something happens and we pretty much like lose a lot of our egg cells, and we are not yet on menopause, we can still produce new oocytes because we have oogonium or stem cells still residing in our ovaries even after birth. So our primary oocyte that is arrested in prophase 1 is inside the primordial follicle. The primordial follicle is surrounded, you could see it under a microscope, and it's actually a very tiny follicle surrounded with one layer of squamous cells. When we're born, okay, when we're born and throughout our life until our menopause, the primordial follicle begin to grow and develop. And before puberty, all of the developing follicles pretty much will undergo atresia. The primordial follicle will now pretty much like mature into a primary follicle. The difference between a primordial follicle and a primary follicle, besides its maturity, it takes a full year from a primary for a primordial follicle to develop to pretty much like develop into a primary follicle, is actually the uh, type of cell that surrounds it. A primordial follicle um, has a layer of squamous epithelium. Meanwhile, your primary follicle has a layer of cuboidal epithelium. You could see here, these are flat cells surrounding this follicle here. Here, the primary follicle will have cuboidal cells surrounding it. So, oogenesis begins pretty much in females during the fetal period. It takes years to complete. The primordial follicle develops in the fetus, and the primary oocytes are arrested in prophase 1. Only a small fraction of these cells that you have, the hundreds and thousands of cells that we have when we were born, is going to be recruited into the pool each month. Each month, our ovary recruits into its pool something like, with the counts of about 5 to 10 uh, follicles that would have uh, oocytes, primary oocytes in them that would have almost like the same age and could at any time pretty much, we just, I have to pick up from where I left off. I'm sorry, I had to hydrate. I needed a cup of water there for a while. So let's continue with what we're saying. Okay, so when where we are, we left off with the primary, um, the primordial follicle maturing into the primary follicle and into the secondary follicle. Meanwhile, the egg inside it will be your primary oocyte. The primary oocyte would reside inside the primordial follicle and the primary follicle for years, okay, and will start, and they are actually suspended under prophase 1, and they will start to pretty much like continue on and move on with meiosis 1 during puberty. So um, the primary oocyte now will continue on and move on into meiosis 1 and would eventually become a secondary oocyte. The secondary oocyte is the one that's going to be ovulated. When ovulation releases the egg itself, that egg that's going to be ovulated has already undergone the first meiotic division and therefore is considered to be the uh, secondary oocyte already. And the ovulation will happen only during puberty. So oogenesis really started from even before we were born, and it'll take years pretty much to complete. The primordial follicles will develop in the first fetus, and then the primary oocytes are actually arrested in prophase 1 when we are in the fetal stage, and only a small fraction of those oocytes are actually going to be recruited in the pool of oocytes that's going to be part of the uh, monthly monthly maturation process, and only one follicle would actually carry the one egg that will be ovulated for that month. The rest of the other members of the pool that will not be ovulated will undergo atresia. They will just be reabsorbed by the body. They will just die. So the production of primary oocyte occurs only in the fetus. Unlike in the spermatogenesis, if you remember the spermatogenesis, our the male sperm actually started in its production only during puberty. which means that the sperm cells are not going to be recognized by the what do you call this, by the white blood cells of the male. And that is the reason why we have, just like what I mentioned in the previous chapter, in the first part of this chapter, that um, inside the testes, the Sertoli cells actually form the blood sperm barrier. It is actually a barrier to prevent the sperm cells from getting out of the testes and escaping into the bloodstream, because in the bloodstream they're going to be killed. They're going to be considered as foreign body because the white blood cells do not recognize them as self, because when they were born and the what do you call this? They were born after the white blood cells has already gained immunocompetency. So the white blood cells do not really know them. Unlike the spermatogenic cells, the oogenesis, on the other hand, is actually fully recognized by the female body as self, because our egg cells started from the fetal stage. So the eggs are actually recognized as self. So the production of the primary oocyte occurred in the fetus and has arrested itself under prophase 1 and would resume only meiosis years after later, and that's going to be in puberty. It will become a secondary oocyte in meiosis only at the time that it's actually ovulated. And it will continue, after it has already been ovulated, it is going to be ovulated and will again be meiosis 1. A secondary oocyte is again going to undergo the second meiotic division, but will be arrested in metaphase 2. So the secondary oocyte is actually arrested under metaphase 2. It is not going to proceed until the end of the second meiotic division. But if there is pregnancy, if there's going to be like fertilization, then the secondary oocyte will assume meiosis 2, will resume a meiosis 2, will move on until there's going to be like a second meiotic division. And the second meiotic division will now form the fertilized egg and a polar body. So let me see if there's anything at all real that needs to be discussed. Okay, something here. Okay, so this is your primary oocytes. From puberty to menopause, it now starts to regularly undergo, well, different sets of eggs will now be on a monthly basis, will now undergo maturation. And this mature egg that's going to be ovulated will have to undergo the second meiotic division right here, but will not have the second meiotic division until a sperm has penetrated and has actually fertilized this egg. After fertilization, this egg will now undergo completion of meiosis 2. Okay, remember, meiosis 2 will only be completed if the sperm penetrates the oocyte. So the total number of polar bodies that is produced in the entire meiosis or oogenesis is actually 3. And the first meiotic division, there's going to be a big egg that's going to get all of the cytoplasm, including the cytoplasm of the sister, the other sister here. The sister here becomes a polar body, has very little cytoplasm, but will also undergo the second meiotic division right there, but will also produce 2 polar bodies. So besides these 2 polar bodies, the second meiotic division will produce 1 big egg. Again, this egg here will get the cytoplasm of the second polar body. And so you have 3 polar bodies all in all. So you have really, like spermatogenesis, you have 4 daughter cells at the end of the at the end of the second meiotic division. But out of that four, only one is actually a functional egg, and the three are actually polar bodies. Meanwhile, in the follicles, your secondary follicles that would have been like releasing, or that would have popped and would have released the oocyte, the ovulated oocyte, this secondary follicle will now regress and will become a corpus luteum. Corpus luteum is a gland that would be producing progesterone. This is going to produce progesterone in preparation for pregnancy, because we are looking at an egg here that's been ovulated, and the body, the female body, is expecting a possible pregnancy, and so everything is, all of its actions will be to prepare for the possible um, pregnancy. And so progesterone is actually going to develop more the uterus, the womb, in preparation for the baby. So after the division of meiosis 1 is complete, two haploid cells of different sizes are produced, and you have the first polar body right here. And this is just to review what we have already mentioned in the previous slide. And after this is actually your secondary oocyte, which is already the ovulated oocyte, but it will have the secondary division, meiotic division, arrested under metaphase 2. Now, when a sperm fertilizes the secondary oocyte, meiosis 2 is going to be completed. Therefore, in the end, all three polar bodies plus one ovum is going to be the byproduct of the second meiotic division. And here is a good uh, picture, a good diagram comparing oogenesis and spermatogenesis. And pretty much the number of functional gametes between oogenesis and spermatogenesis differs. Oogenesis produces only one, okay, one viable haploid ovum with three, okay, it says one, two, and then three polar bodies. And these polar bodies are not viable. Spermatogenesis produces four viable sperm. And the occurrence actually during the lifetime, oogenesis begins during the fetal life and ends in menopause. Spermatogenesis begins at puberty and continues into old age. And that is the reason why the sperm cells would need to reside in the scrotal, in the testes, and would be around the Sertoli cells, or the sustentacular cells, within the sperm, the blood sperm barrier, to prevent it from escaping into the blood, because they get killed there, because they are not going to be recognized by the white blood cells as self, because they began their development during puberty. And by that time, during puberty, the immunocompetence of the white blood cell of the male has already started, and they know already what is self. So they do not know the sperm cells to be part of the cells, because they were born later. The error rates also is very different between the two. The error rates in spermatogenesis is about 3 to 4%. In oogenesis, the error rate is about 20%. This has got something to do with the rigidness in the checkpoints of spermatogenesis. Spermatogenesis has a more rigid checkpoints. And this is actually your table that is going to serve as a useful tool for your studying. And so let's take a look at the development and fate of the ovarian follicles, looking at them, and what do you call this, in uh, microscopic view. The follicles and oocytes may take nearly a year to mature before ovulation can occur, and the maturation process occur in two phases. Step one process uh, pretty much uh, step one is actually it's several steps but in two phases. Okay, the first one is what you call the maturation, uh, the non-antral maturation, and this is actually the follicular maturation without the antrum. And then the other one is the antral maturation, and that's actually with the antrum. The difference between the two is just the presence or absence of an antrum in the follicle itself. So the primordial follicle, okay, the primordial follicle is uh, encircled by a line of squamous cells, which is squamous-like cells, um, and pretty much that's how you recognize them as primordial. The cell surrounding the egg is actually squamous-like. Then um, it becomes a primary follicle. The primary follicle pretty much would uh, have the cells surrounding it not anymore squamous-like, but cuboidal-like. And the oocyte at this point already would start to secrete a glycoprotein-rich substance and will form a layer of protein surrounding it. And that particular line surrounding the egg is actually the protein substance, which you call the zona pellucida. It is actually a protein capsule of the egg itself. Then you have okay, well, here you have phase one, which is gonadotropin independent preantral phase. The preantral is without the antrum. Then you have the second phase, which is the antral phase, and the difference between them is only the presence of or absence of the antrum, which is, if you have the antrum phase is stimulated by follicle stimulating hormone and luteinizing hormone. The dominant follicle in the preantral phase is actually the primary oocyte. This will now start to resume the arrested uh, meiosis 1. When we were born, it was arrested in prophase 1. Up until we are in puberty, then from meiosis 1, prophase from prophase 1, meiosis 1 will now continue. And as it matures during ovulation, let me click on it. Okay. The primary follicle now becomes a secondary follicle during ovulation. The secondary follicle becomes an antral follicle. So right here, this is actually already still your primary oocyte. It becomes a secondary oocyte the moment it finishes up with the first meiotic division. And immediately after that, it is going to be ovulated. Okay, so the granulosa cells, you're now in step 3, the granulosa cells. And the oocyte, the granulosa cells are the cells that are surrounding it, all right? In the primordial cells, the granulosa cells are squamous-like. In the primary follicles, the granulosa cells are cuboidal-like. Here, it will have multiple layers of cuboidal still in the primary, in the secondary follicle, but still a primary oocyte. But over here in the early vesicular follicle, this is still a primary oocyte, but you could see the development of antral spaces and it's slowly filling up with antral fluid, okay, as the follicle is maturing. Here you have a vesicular follicle already. You can see the granulosa cells uh, surrounding the fluid which you call the antrum, and then you have another set of granulosa cell that that is actually surrounding the actual egg itself. And you could see also the zona pellucida, which is actually a layer of protein surrounding or encapsulating the egg. And over there, the zona pellucida is blue. And over here, the zona pellucida is darkly staining. You could see it. But just know that the zona pellucida is actually um, a protein substance that encapsulates the egg itself. So pretty much in this particular step, you have thecal cells. The thecal cells are no right here. The thecal cells. There you go. The thecal follicula. The thecal cells secrete hormone in response to the luteinizing hormone. And the second now, immediately after this, you now have a secondary follicle. This particular secondary follicle is now very big. It would still have a primary oocyte inside it, but because it has a very big antrum, you call it a secondary follicle. This secondary follicle stage will end when the liquid accumulates between the granulosa cells, and pretty much um, it will it will create big pressure or large pressure inside it and will push itself outside of the egg, but it's inside of the egg. So it just protrudes out and is getting ready to pop. It continues to, the antrum continues to, um, the antrum fluid continues to build up pressure until pretty much it pops and it pushes the egg out. So okay, so the antrum expanded and the fluid inside it created pressure. It pushed the follicle to open, and the egg now is together with the corona radiata is now going to be pushed outside, and that is already ovulation. At this stage, after ovulation, the follicle, the secondary follicle that was emptied, will now become a corpus luteum. These particular cells, the granulosa cells, what used to be granulosa cells, will now become the glandular cells that would produce progesterone in preparation for pregnancy. About 1 or 2% of ovulation that is released, 1 or 2% of ovulation release more than one secondary oocyte. Is that possible? Yeah, it is possible. And that's the reason why we have what we call fraternal twins. Fraternal twins are not the same as identical twins. Identical twins result from fertilization of one oocyte, then a complete separation of the daughter cells during the first division uh, during gestation. In some women, oocytes may be released at times unrelated to hormone levels. After ovulation, the ruptured follicle will collapse, okay, and would eventually become a corpus luteum. Sometimes, because it's actually a rupture, it will bleed. And under the microscope, if you can see blood within the ruptured follicle, that is not yet a corpus luteum. That is actually what you call a corpus hemorrhagicum because of the blood, which eventually may be absorbed. Now, after after corpus luteum, if there is no pregnancy, corpus luteum will actually for 14 days continue to produce progesterone until pretty much uh, there is no pregnancy. When there's no pregnancy, this corpus luteum will become a corpus albicans. A corpus albicans is actually nothing but just a scar tissue, a collagenous unit that follows a corpus luteum. Now let's go to the regulation of the female reproductive system. Let's take a look at the hormonal regulation of the female reproductive system. Okay, just like what I mentioned before puberty, the ovaries secrete small amounts of estrogen already. And this particular small amount of, of estrogen would inhibit the hypothalamic release of gonadotropin releasing hormone. So right here, there is actually something that is released, that is stopping the hypothalamus from releasing gonadotropin releasing hormone during the before puberty, because we are not supposed to be ovulating eggs yet. Then you cannot have any development of any oocyte if your gonadotropin releasing hormone will not be produced or will not be released in the hypothalamus. And that's actually happening because a good amount of estrogen, here you go, a good amount of estrogen or slightly elevated estrogen will pretty much like inhibit the release of gonadotropin releasing hormone. And it acts on the ovaries. Now, this event will continue until the adult cyclic pattern is achieved. And then we have already menarche. Menarche is actually the start of menstruation. Now, during the ovarian cycle at the beginning, during puberty, the gonadotropin releasing hormone, right there, the moment the estrogen level drops down, the gonadotropin releasing hormone will now be produced by the hypothalamus. The gonadotropin releasing hormone will stimulate the release of the follicle stimulating hormone and the luteinizing hormone. And both the follicle stimulating hormone and luteinizing hormone would stimulate together. They will stimulate the maturation, the growth of the follicles that carry the egg inside it, and they will secrete the sex hormones. So you could see that the sex hormones actually are the ones, the androgenic as well as the estrogen, that's actually going to be stimulated in their secretion. Now, the LH and the thickle cells, pretty much, they're also stimulated to produce the androgens. And the granulosa cells pretty much will convert to granulosa cells, will convert these androgens into estrogen. And that would further increase the level of estrogen in the body. The level of estrogen in the body, together with the other estrogen produced in the conversion of androgens to estrogen, and inhibin, okay, which is a production of what they call this on the ovary, they both will have a negative feedback that would pretty much like stop the production of LH and FSH if the estrogen level is already too high. Okay, so positive feedback stimulates gonadotropin release. This positive feedback, which means estrogen levels continue to rise as a result of continued release by the dominant follicle. When levels reach a certain critical high value, a brief positive feedback occurs in the brain and the anterior pituitary. This event will trigger an LH surge. The LH surge right here is important because this is the one that would prompt ovulation and formation of the corpus luteum. A high estrogen level triggers the release of stored LH, okay, And okay, where's actually that stored LH uh, there, and it would actually and some FSH by the anterior pituitary. This LH surge triggers ovulation. The LH surge also triggers the primary oocyte to complete meiosis 1, to become a secondary oocyte, and that's actually already pointing to ovulation. Whenever there is actually an LH surge and a complete maturation of of the secondary follicle and ovulation proceeds, this is actually now going to go into the next level, which is uh, the effect by which the effect of ovulation on almost like everything as part of the secondary sexual characteristic, which is vascular permeability, okay, and increasing local vascular permeability, um, triggering the inflammatory response, promoting the release of metalloproteinase enzyme that weakens the ovarian wall, and pretty much it stops the blood flow to the protruding follicle, causing the wall to thin out further and rupture the follicle. So the oocyte, together with all of its granulosa cell, and you call that the corona radiata, exits, accomplishing ovulation. Shortly after ovulation, the estrogen level would decline. Okay, shortly after ovulation, the estrogen level decline. The LH pretty much transforms this ruptured follicle into corpus luteum, and the corpus luteum starts to produce progesterone. And some estrogen also is being produced almost immediately. Progesterone helps maintain the stratum functionalis the until until the ovary is pretty much like going to stop the production of progesterone because it will sense that there was actually no pregnancy. Okay, so if the egg did not move on and continue its meiosis to division, then there's already a signal for the corpus luteum to stop its production of progesterone because there is no pregnancy. So, um, the rising the rising level of progesterone before they stop progesterone, the rising level of progesterone creates a negative feedback from um, uh, pretty much that inhibits the LH and FSH release, or inhibits the further release of LH and FSH. And together with inhibin and the rising level of estrogen and progesterone, this particular negative feedback will stop the hypothalamus from producing any more gonadotropin releasing hormone. So if absolutely no fertilization occur, your ovulated egg will not get into a second meiotic division. Then the corpus luteum will degenerate. The luteinizing hormone level will start to fall, causing a sharp decrease in estrogen and progesterone, which in turn ends the blockage of FSH and LH secretion, causing the cycle to start all over again. So it starts again from the beginning. The oocyte is actually activated 12 months prior to ovulation, but matures 14 days before ovulation. So it is really a lengthy process. So let's take a look at the ovarian cycle. Okay, so during the follicular phase, the ovarian cycle is a 28-day cycle, and it's actually divided into two, and in the midpoint is actually its 14th day where ovulation happens. In the first half, you have the follicular phase. This is the development of the follicles. After the follicle has developed, the secondary follicle will now release the egg. That's already ovulation. And this particular follicle that is left empty will now regress into a corpus luteum, which will now start to produce progesterone in anticipation of pregnancy. This is actually what you call the luteal phase. Now, during that dominant phase, during that particular phase, also looking at the what do you call it, the uterus itself, during the first 5 days, that's actually your menstrual cycle. After the fifth day, all the way to the 15th to the 14th day, that's actually the proliferative phase. In this particular menstrual phase, the stratum functionalis of the previous month is actually going to be sloughing off, and it's going to be part of the menses. Then during the proliferative phase, it's going to be regenerated. It will be regenerated to form again, reform again. And during the secretory phase, it will start to pretty much like produce progesterone in preparation. It will prepare itself for the possible pregnancy. So here is actually now a different view of the 28-day cycle, still with ovulation being in the middle. The proliferative phase and the menstrual phase is actually when the stratum functionalis gets sloughed off and it will be reforming. And then during the secretory phase, after ovulation, the female body would think that there might be pregnancy and therefore they have to prepare the uterus again. And that's actually in the secretory phase. Now, only 10 to 15% of women have a 28-day cycle. So the follicular phase pretty much varies in these women. But the luteal phase, this phase right here, the last 14 days, stays as 14, which means this phase here does not become longer than anything. But the reason why some women will experience longer than 28 days cycle is because their follicular phase is actually longer. Here's another look at the menstrual cycle, showing us the different aspects from the production of LH and FSH, which is actually at its peak during ovulation. As a matter of fact, just like what I mentioned, the LH, the surge of the LH is the one that would prod ovulation to start. Okay. And during that point, you have also a peak in the estrogen. And pretty much progesterone after the ovulation will start to peak also in preparation for pregnancy. And the effect of progesterone is actually the enrichment of the what do you call this, the urine lining, and that is during the secretory phase. Okay. So, looking at the role of both the estrogen and progesterone. Estrogens promote oogenesis and follicle growth in the ovary. They also exert anabolic effect on the female reproductive tract. They support rapid, short-lived growth spurts during puberty. They also induce the secondary sex characteristic development, such as the growth of breast, increased deposits of subcutaneous fat along the hips and the breast, the widening and lightening of the pelvis. And estrogen also has metabolic effects, such as maintenance of low total blood cholesterol, which is good, and high density levels, and high HDL, high density lipoprotein levels, which pretty much they also facilitate calcium uptake. Progesterone works with estrogen to establish and regulate uterine cycle and pretty much promote changes in the cervical mucus. The effects of placental progesterone during pregnancy inhibits uterine motility and helps in preparing the breast for lactation. This particular functions about estrogen and progesterone is an addition to what has already been mentioned right here in the slide. And of course, altogether, the one I mentioned and the ones that are listed here, you have here a summary of the hormonal effects of these hormones, including testosterone, which is available to you for um, for your uh, for your pretty much like studying. And this is available in your ebook. So let's take a look at the female sexual response. First of all, the female libido is prompted by the hormone that is produced in the adrenal cortex, the androgenic hormone, which is your dihydro epiandrosterone. It is an androgenic hormone produced in the adrenal cortex. And the female sexual response is initiated by touch and psychological stimuli. So if the female is worried and under stress and everything, and is not relaxed, then the female will not be aroused. The clitoris, the vaginal mucosa, the bulb of the vestibule, and the breast would engorge with blood, and the nipples will become erect as part of the sexual arousal. The vestibular gland, which is located under the under the labia minora, secretes lubrications in the vestibule. Orgasm is accompanied by muscle tension, an increase in pulse rate and blood pressure, and rhythmic contractions of the uterus. And oxytocin plays a major role in our orgasm. The females have no refractory period after orgasm and can experience multiple orgasms in a single sexual experience. Now let's take a look at some homeostatic imbalances. Let's start with sexually transmitted infections. These are the STIs and STDs. STIs are infections caused by bacteria or viruses, parasites that may not show symptoms. STI is short for sexually transmitted infection. STD is sexually transmitted diseases and are results of untreated STIs that progress to cause noticeable symptoms or health complications. STIs are also called sometimes sexually transmitted diseases or venereal diseases. And the United States has the highest rate of infection among the developed countries. Latex condoms help prevent the spread of these STIs. And the STIs are the single most important cause of reproductive disorder. So we hope to pretty much like prevent STIs as much as possible. The first sexually transmitted infection is actually chlamydia, and it's brought about by a bacteria which we call chlamydia trachomatis, and can be contracted from the birth canal by newborns, and is responsible for about 25 to 50% of all diagnosed cases of pelvic inflammatory disease. Symptoms will be pain while you are urinating, penile and vaginal discharge, abdominal, rectal, or testicular pain, painful intercourse, and irregular menses. Pretty much only 20% of women and 10% of men have symptoms. If left untreated, this can lead to sterility. Newborns usually pick up bacteria from birth canal and can develop conjunctivitis and respiratory tract infection, including pneumonia. Treatment for this will be antibiotics. And we have Neisseria gonorrhea, which causes gonorrhea. It is a bacterial infection of the mucosa of the reproductive urinary tracts. And pretty much most of the infections in gonorrhea are asymptomatic. In males, symptoms can include urethritis and painful urination, discharge of pus from the penis, and if left untreated can cause urethral constriction and inflammation of the duct system. In females, symptoms can include abdominal discomfort, vaginal discharge or abdominal urine bleeding, and possible urethral symptoms. If left untreated, it can result in pelvic inflammatory disease and sterility. The treatment, again, because it's a bacterial infection, will be antibiotics. If there's going to be if it cannot be treated and cannot be corrected using one antibiotics, some clinicians will be doing double antibiotic. Then we get into syphilis and trichomoniasis. Syphilis is caused by Treponema pallidum. And this yellowish squiggly things is actually your treponema. And syphilis is a bacterial infection, and infected fetuses can die or die shortly before birth. Bacteria invades the mucosa or even a broken skin. Infection usually is asymptomatic for 2 to 3 weeks, and then a painless the painless cankry appears at site of infection, but would disappear within a few weeks. Trichomoniasis is a very common infection among women, but the men is actually the carrier, and they are asymptomatic with trichomoniasis. They are only carriers, but thankfully enough, they are easily and inexpensively treated. 70% of women, though, have no symptoms, and 30% have yellow-green vaginal discharge with very strong odor. And we have the human papilloma virus, the HPV. The human papilloma virus pretty much is the most common STI in the United States, and over 50% of adults are infected during their lifetime. And this is actually the main cause of what we call genital warts, ugly warts that's actually going to pop up around the human genital area. 80% of cases of invasive cervical cancer is linked to strains of HPV. It can also cause some penile and anal and oropharyngeal cancers. And vaccinations pretty much can guard humans against the most common cancer-causing strains. It is recommended for boys and girls before they become sexually active. Then we have genital herpes. It's caused by herpes simplex virus, one of the most difficult human pathogen to control because people who have this will not know that they are infected. Only 15% would display signs of infection. It is characterized by lengthy latent periods and then would flare up with vesicle formation. It can be passed on to the fetus, and congenital herpes can cause really malformations of the fetus. The treatment will be antiviral drugs and can reduce the duration and intensity of the flare-ups. This is really hard and lengthy to manage. So let's take a look at the development aspect of the reproductive system. We are going to continue this also during our study of genetics and gestation. So, out of the 46 chromosomes that we have in our body, 2 of them are sex chromosomes, the X and the Y. If a person has both X and Y chromosome as their sex chromosome, then the person is a male because of the presence of the Y. If the person has two X chromosome, which is this large chromosome right here, then the person is a female. And so the males will have, when they do spermatogenesis, will be producing 50% of their sperm being Y sperm. They will carry one Y chromosome. And the other half, the other 50%, will be X chromosome. So technically, if you're going to be doing, genetics, for every couple, the percentage of having a boy and a girl is always 50-50. Every time there's actually a pregnancy, there's actually 50% chance that that pregnancy can be a boy or a girl. All right? But that percentage will probably not be the same according to statistics. And when we get into genetics and gestation, I'm going to discuss with you why statistics do not always agree with the scientific uh, design of probability. So, if a fertilizing sperm delivers an X chromosome, where's the sperm right here? There. If it delivers an X chromosome to the egg and fertilizes, this sperm fertilizes the egg. Now the resulting fetus is now going to have an XX sex chromosome, and that's going to be a female. If the fertilizing sperm delivers a Y chromosome and the egg has an X, so now your resulting fetus is going to be an XY or a male, a baby boy. So pretty much the reason why what do you call this, the men or the male will have their testes outside of their body cavity is because of the gene which we call the SRY gene. The SRY gene is a master switch and is located on the Y chromosome and pretty much initiates the descent of the testes and also initiates its development and the maleness of uh, the fetus. Without the Y, without the SRY gene, okay, if the SRY gene of the male has mutated, then the male testes will not be descending out, and so the male will end up being a female. Yes, there are XY females, and we are going to be discussing this when we get into genetics. So now let's take a look at non-disjunction, which is a problem in meiosis. Non-disjunction is the failure of homologous chromosomes or sister chromatids to separate properly during meiosis. This results in gametes with an abnormal number of chromosomes, a condition which we call aneuploidy. Now, this error can occur in either the two meiotic divisions, could happen during meiosis 1, non-disjunction during meiosis 1, or non-disjunction during meiosis 2. Let's revisit the normal meiosis. Right here, normal meiosis pretty much starts with the parent cell. Right here, these are already homologous pairs of chromosome. They have already like duplicated itself, so interface has already happened. During the first meiotic division, these homologous chromosomes will separate. They have already undergone crossing over. So now the resulting gametes is now haploid during the first meiotic division. After the first meiotic division, the resulting daughter cells are already gametes. Already haploid gametes. No, they're not yet gametes, haploid cells. Now this will now undergo a second meiotic division, where each of these homologous chromosomes will be dividing via their centromere, and each of them will produce again a single-stranded, uh, bearing single-stranded chromosome per cell, and these single-stranded chromosome bearing cells are also haploid. So from the product of the first meiotic division and the second meiotic division, both cells are actually haploids. Only the mother cell will be diploid. And because of the presence of crossing over during the first meiotic division, then you know that the daughter cells are not going to be identical to the mother cells. They're going to be totally different because they have mixed already the sperm, the paternal and the maternal DNA during crossing over. So this is actually your normal meiosis. What happens during non-disjunction? Well, during the first meiotic division, right there, during the first meiotic division, these two needs to separate from one another, right? But it so happened that here, they did not separate. Here, the chromosome number here is only 2, but the chromosome number here is 4. 1, 2, 3, 4. One of the chromosomes did not separate. So the resulting daughter cells, between the two resulting daughter cells of the first meiotic division, the one daughter cell will not have the homologous pair because the other homolog went with the other cell. So when they divided this one, when this one divided, it will result in a haploid -1. The chromosome number of this daughter cell is haploid -1. Where did that one go? Why is it -1? Well, it went into the other cell. When this cell divides, it becomes a haploid +1. Where did it come from? Well, it came from that guy there that did not want to pretty much separate from its homologous chromosome. It went in the same cell. So when it divided for the second meiotic division, then the resulting aneuploid is n+1 for both cells, and the resulting aneuploid for the other cell will be an n-1. All daughter cells are abnormal when your non-disjunction happened during the first meiotic division. What if the non-disjunction happened during the second meiotic division? Here, in this particular case, the first division was perfect. Okay, the homologous chromosomes during the first meiotic division managed to successfully separate. There you go. But the resulting daughter cells here, one daughter cell successfully managed to do a perfect second meiotic division. So no problem, their daughter cells will be a perfect haploid. But for this other cell here, during its second meiotic division, one of the chromosomes did not separate via the centromere. So it went with one of the daughter cells. So one daughter cell will have one missing chromosome, and this other daughter cell will have one more chromosome. This one will have an aneuploidy that is n+1. This one will have an aneuploidy that will be n-1. So when the non-disjunction happens in the second meiotic division, then 50% of the chromosome will be 50% of the daughter cells will have chromosomes that are normal haploid. The other 50% will be abnormal. So let's make a generalization here. When non-disjunction happens in meiosis 1, in the first meiotic division, all of the daughter cells will have aneuploidy. 50% will be n+1, 50% will be n-1. When the non-disjunction happens in the second meiotic division, only in one of the daughter cells, then the resulting imperfection will be 50% of the daughter cells will be aneuploidy n+1 and n-1, and then the other 50% will be normal. That's it, guys, for chapter 27, second part. I will see you in chapter 28.